Greetings. What I'm going to do for you all today is to review a few abstracts and posters that were presented at the last American Headache Society scientific meeting based on headaches and particularly post-traumatic headaches. I'm doing this admittedly rather late. The scientific meetings from the American Headache Society, these occur every year in June. It's now September, everybody's back to school, everybody's getting ready for fall, and everybody has their pumpkin spice lattes now. Myself, I'm not particularly into pumpkin spice lattes and coffee. I drink other things. But getting into this, I just wanted to review a few interesting finds and share a few things with you. But before I do that, I want to make a little digression here, which will help clarify things later in this presentation. There's this concept that we have in the United States of evidence-based medicine. In the United States, we are bound by evidence-based medicine. Anything that we inform a patient is quote unquote true, we say so because it has been quote unquote proven, so to speak, in good medical research studies, hence evidence-based medicine. On the other hand, there's clinical experience. Sometimes we say things to be true just because we've seen these things over and over again, and we just know it to be true, even if nobody has done a good medical study to show that our hypothesis is true. Now, if I've confused you a little bit, allow me to clarify. As a neurologist who does treat individuals with post-traumatic headaches, I can tell you based on my clinical experience, there is absolutely no question whatsoever that individuals who have a history of migraines before they have a concussion are going to have more frequent migraines and more severe migraines after their concussion. I can tell you that to be true based on my clinical experience. I've never had taken the time to write up all my cases and show the statistics and the percentages, or even to compare those individuals to another group. But somebody did, okay, at the scientific meeting. The Toronto Concussion Study had made this very conclusion based on 302 cases that they had examined, that certainly individuals who have a history of migraine have more severe migraines and are more prone to persistent post-traumatic headache after their concussion. Now, for some of you out there, you might say, well, intuitively that makes sense. You don't really have to be a doctor to figure that out. That kind of sort of makes sense. But a few things I would just like to mention about that conclusion. When we see patients in the clinic after their head injury and are having a bad time with headaches, I always ask patients, well, did you have migraines before your injury? And sometimes they tend to downplay it. Well, yeah, I kind of sort of did. Maybe I did. Well, yeah, I did, but it was only every so often. Well, it's still important to know because it goes right along the lines of that conclusion. Maybe in the past you didn't have headaches all the time, but you did. So it's certainly interesting because these individuals may have different brain chemistry than people who did not have a history of migraine and then were subjected to a concussion. Could we make the hypothesis that individuals who do not suffer from migraines are not going to suffer from persistent post-traumatic headache? I don't know if I can really provide the answer to that question, but it's a thought. The other reason I bring this up is because in the world of concussion, particularly sports injuries, we like to screen people, right? If you play sports in Pennsylvania, uh, your high school might make you go get an impact test, just a baseline impact test. Or you may have to see somebody for some pre-screening. You may have to do some cognitive test or fill out some questionnaires before you engage in sports. And the idea of that is they compare your scores before injury and after injury and see where you stand and make decisions on whether you can return to play based on that data. But the reason I think that this is very important is, particularly as a neurologist, when you are screening people for sports and you see that they have a history of migraine, that should raise a flag is a major risk factor. So when those individuals have concussion, you should immediately perhaps be thinking about jumping in and providing immediate treatment for migraines, or being on your guard very early because you may start to see those migraines emerging and becoming more frequent and more severe. And unfortunately, very unfortunately, in my profession, I would say that it takes about 6 months to a year, and oftentimes even over a year, before those people end up at a neurology office. There's quite a significant delay, and that is unfortunate. So, kind of circling around and bringing us all together, I suppose what I'm saying is this. When we're screening people for sports or any type of activity where they are at risk of sustaining a concussion, we really need to hone in on that history of migraine. We should not minimize it. Even if the person's well controlled, even if the person says, you know what, I just get a migraine once every 2 months, it's no big deal, I take some Excedrin, life goes on. You're right, at that point in time, it is no big deal, but it is definitely a risk factor for worse things later. So we really need to take that into consideration. Okay, moving on. This next one is near and dear to my heart. A study by the VA and Madigan Army Medical Center, my alma mater for residency, they came to this conclusion that perhaps prazosin might be useful for treating post-traumatic headaches. However, this was in 15 patients versus 8 placebo. I don't want to sound like I am quote unquote bashing my former colleagues here or being a bit critical, but I'm going to be. I'm sorry. Again, I want to go back to that thought of clinical experience versus evidence-based medicine. Now, in this particular study, 15 people treated versus 8 placebo, that's not a particularly strong study. Now, I commend these individuals for doing the study. Honestly, I do. And I think that this is an interesting find on their behalf, but it's a weak study. And the reason why I'm going to call them out as a weak study is because as a former military physician, I had probably seen hundreds of individuals who had a history of PTSD that were taking prazosin and their headaches weren't any better, because that's what I was seeing them for their headaches. It would have been nice if these individuals were taking their prazosin for the nightmares related to their PTSD and their headaches improved, but that wasn't the case. That's why I was seeing these people in my neurology clinic. I've likewise seen the same thing in the civilian setting. Now, the PTSD patients that I see in the civilian setting, different stories, okay? These are individuals that, if they have a history of post-traumatic headache, unfortunately, many of my patients were subjected to domestic abuse or physical assault. versus the veterans and the active duty soldiers where we're talking about combat related injuries, different settings. But let's just back up for a moment, okay? One of the things I've said before, and you may have heard me say this in a different presentation, one of the downsides of treating soldiers and veterans is the following. Most of these individuals are young and healthy. If they're on active duty, they have to meet physical fitness standards. Whatever branch of the military they are in, there's some type of physical fitness standards that they have to meet. And most of these individuals are very healthy. So if we focus on the Army for a moment, because that's where I practiced, it was always unfortunate to see a young person in maybe their 20s that was completely healthy, maybe be subjected to a blast injury. So they come back to the United States and they have a post-deployment screening, and the next thing you know, well, I'm a little depressed, so they're on an antidepressant. I'm anxious and panicky, so now I'm on an anxiolytic. I can't sleep at night, so now I'm on something for sleep. I have PTSD and have nightmares all the time, so now I'm on prazosin, which is what we were just talking about. And I have back pain, so now I'm on hydrocodone, which was a favorite thing to be prescribed in the Texas region. And I have headaches, so now I'm on Furosec. Please don't prescribe your patients Furosec. Different talk for a different day. And now I'm going to go see a neurologist, and that person's probably going to prescribe me something daily to take for migraine prevention and something intermittently to take for abortive therapy. So I am a young, healthy, 20-something-year-old individual, or at least I was a year ago. Now I'm on at least 8 medications. Now let me ask you people something. This doesn't require medical knowledge or high IQ to figure this out. If you went from no medications to 8 medications virtually overnight, how would you feel? Now, the reason I point this out is because I am all about finding the key medication, okay, what I call the key medication. If a person has PTSD and they are prescribed prazosin for their nightmares related to PTSD, and I can treat their nightmares and their headaches with one pill, that would be great. I would be all for that. So while it might seem as if I'm bashing this study, I am at the same time sitting on the line as a cheerleader saying, I want to see more. Okay, I want to see stronger evidence of this study. I would like somebody to do a much stronger study to show that this could be true, to show that it might be very true that if we just place somebody on prazosin for their PTSD-related nightmares, that it will also help with their headaches. Because if that is true, then that's great. That means I only have to prescribe you one medication. You don't need your prazosin for your PTSD and some other medications for your headaches. I can reduce polypharmacy and your side effect profiles. Unfortunately, based on my clinical experience, seeing hundreds, if probably not well over 1,000 people at this point in time that have been on prazosin for their PTSD-related nightmares and have headaches, I'm skeptical. So I would just say more on that in the future. Let's sit on the sidelines and hope that we see better things in the future for something like this. Okay, last and certainly not least, George Washington University looked at some individuals with botulinum toxin, Botox, and Erenumab, Aimovig, in the post-traumatic headache setting. And what they found out was that both medications seemed to do a pretty good job. 6 months later, most of these individuals were reporting less headaches. Now, a few things I want to point out. Again, back to that clinical experience. When I was a military physician seeing many more people with post-traumatic headache. We used an incredible amount of Botox on those individuals. I felt that Botox was very helpful in those settings, but I will also tell you that my access to Botox in the military was much easier than it is in the civilian setting. Okay. If I saw you as a neurologist in the Army and I wanted to use Botox for your migraines, all I had to do was write it out on a little prescription pad, hand it to one of the LPNs that worked in our clinic. They would carry it downstairs to the inpatient pharmacy. The pharmacist would provide them the vial of Botox, and we'd be done. There'd be no pre-authorization and co-pays and co-insurance and all that garbage. It was actually a very nice setting to practice in under those circumstances, to be honest with you. Now, in the civilian sector, I am met with those barriers that I have to seek permission for all these things. And that's a little bit of a delay, actually. But I will say that based on my clinical experience, I did see a good number of people have clinical response to Botox with their post-traumatic migraines. Now, you have to keep in mind now this Aimovig, the Evidencebased, and some of its competitors even, Emgality, Ajovy, these things did not come out until 2018. They were not FDA approved until 2018. Botox was FDA approved for the treatment of chronic migraine in 2010. And in reality, guys like myself, we were using Botox long before 2010. Okay, again, in the Army, I didn't have to fight. We were using it very differently than what they call the preempt protocol, but we were still using it. So I would say that there's probably floating out there more data on Botox patients than there is for Aimovig patients. But if you get into the science of these two medications and how they work, they both make sense for treating post-traumatic headache. Now, the one thing I'm going to say is, again, if you look at this poster that was presented or this research that was presented, they're talking about 6 months, patients having clinical improvement after 6 months. In other words, what that means is 2 cycles of Botox, 6 cycles of Aimovig, okay? If you look at the data on Aimovig, whether somebody has post-traumatic headaches or not, you may see a dramatic drop in headaches the first month, but you continue to see a drop over 6 months. In other words, it takes time, okay? These things you have to give these medications up to 6 months to see efficacy. Well, that's all the updates I have for you today. I hope that you found this information to be very helpful. If you have any further questions about these things, certainly feel free to contact me and ask more questions. I'd be happy to answer any questions that you may have. Thank you for listening and have a nice day.